Welcome to the first mini battle of the 16th, or the first mini battle of the E-series of organized by Athens Soldier course. My name is Manos Brilakis from the Hospital of Athens, and I would like to welcome you in this first episode. I'm the head of organizing a scientific committee of the Athens Soldier course, and I feel very lucky because this year we have the opportunity to organize our course last February before the pandemic changed our everyday life. So, due to this reason, we decided to postpone our course for next February, and being driven for our passion to communicate and for continuing development, and cover the need of education and communication, we try to do this series, counting down to our main event, to Athens Soldier Course 2020, and this is the idea. So this is the first episode, and I would like to introduce Dr. Antonogiannakis, my director, my mentor, and from Hygia Hospital in Greece, and I would like to tell about this concept.
So, good evening from me. Also, I'm Manos Antonogiannakis. I'm the chairman of the Athens Shoulder course, a course that we organized every year about shoulder surgery. So, after we decided that 2021 we would going to postpone our course and do it in 2022, we thought what we could do in order to be in contact and in touch with all our friends that have been with us in the Athens Shoulder course. And we said, so if we can't go live, why not any course? And thinking what was the most interesting part of our Athens course, it was those discussions and presentations, mainly the discussions after the presentation. And then why not do it through any course every month, being with our friends again, and having the opportunity to share, discuss, present, even fight sometimes about interesting shoulder topics. And this is the Athens Shoulder course, the mini battles, and this is the first one. So welcome, and I hope that we are going to have an interesting and educating experience.
So, for today, I would like we have with us two great good doctors, two great surgeons, very well known in the in shoulder and maybe also in parts of orthopedic surgery above shoulder. So first is the Dr. Klaus, partner of Adidas Hospital, associate editor of KSSTA from Copenhagen, from Denmark. Welcome, Klaus. And also we have the luck to be with us, Dr. Claudio Rosso, Chief of the Shoulder and Elbow Unit, Arthromedics, of course, SKSA board member and professor at Docent University of Basel in Switzerland. And our subject today is the AC joint dislocation. But before starting the lectures, take a moment to vote which is your preference for the management of the vast majority of the acute AC joint dislocation, because we want your participation to be active.
So try to share with us, and we are going to have this mini battle, this discussion, and then see answering questions and finally deciding what will be the best treatment for the AC dislocation. A topic that was discussed 2 years ago in the ESA closed meeting, and at that time, this meeting was something that changed at least my treatment and my experience of AC joints.
So we can start, I think, without further delay. So let's the first mini battle begin. Klaus, I would like to invite you to give your lecture, to see your presentation.
Yes. Can you see it now?
Yes.
Yes, you can see clear.
Okay. Are you ready? Thank you very much, Manos and Manos, for this invitation. I'm going to talk about why I choose primarily non-operative treatment for acute AC joint dislocation. Just a second. So when we have an acute AC dislocation, we have to choose between non-operative treatment or operative treatment in Italy. So the goal of the treatment is to obtain a pain-free, full range of motion and ability to perform overhead in the fastest possible way with the less possible recurrence. Actually, cosmetics may play a role. We didn't know that. This is mainly in males, so still cosmetics play a role. And then I think about the AC paradox, because what do we want with this treatment? Do we want an optimal scapular function, or do we want to treat the X-ray to be normal? In my personal opinion, and I think there is a solid evidence, is that the scapula plays a major role. This is one from our study, just finished the inclusion of number 100. This is a grade 5 dislocation 6 weeks after the injury. You can see he has scapular dyskinesis. He has a grade 5 dislocation. He has a full range of movement. It's not a nice range of movement, but he's very happy. He's satisfied. He has no pain. He already went back to work at this stage. So then we always have to look at the literature. What can the literature tell us? So actually high quality evidence on both non-operative treatment and operative treatment is missing. Studies on non-operative treatment are very sparse, often retrospective and small series. And if you look at the BeeMed, there are numerous hits on level 4 studies on surgical management. And we know from many years now that there are more than 150 different techniques to do this operation. If you look at the literature, there are 4 level 1 studies comparing non-operative treatment and operative treatment, and 3 of these are from before 1985. So this is old knowledge, most of it. But then again, some of our colleagues make this systematic review. We have nearly 1,000 patients comparing operative and non-operative treatment, and they end out saying that in conclusion, there's no clinical difference in functional outcome scores between the 2 treatments. Actually, the patients in the non-operative cohort had a more rapid return to work, but they were also associated with a poorer cosmetic outcome. But we have to know that this is a big meta-analysis. It's probably not optimal conservative treatment, and I know that many of the papers were with little old-fashioned methods like the hook plate, so it's not what we call more modern treatment. Then the most recent study collecting a lot of patients is a Cochrane database system review, and they say the same. They say it's a low quality evidence of nearly everything with this joint, but there's a low quality evidence that surgical treatment has no additional benefits in terms of function, in terms of return to former activities and quality of life at 1 year compared to conservative treatment. There's also low quality evidence that people treated conservatively had improved function at 6 weeks already compared with surgical management. So again, even if low quality evidence, this points at conservative treatment. Then you can say, what about athletes? What about high level athletes? And these are small series, but it shows there's a high greater success for just normal non-operative treatment. 75% return to activity, and Schlegel published a study with up to 100% success rate. So even in quarterbacks, you can return 80% to play faster than you can do by surgery, which has a lot of implements for the sports people. So why choosing primary non-operative treatment? Well, we don't have any precise numbers, but more than 80% regain normal function after 3 to 6 months. We know that recovery is shorter after non-operative treatment. Studies show that return to play is 18 days median, where surgery is at least a half a year. And we, of course, complications are rare in non-operative treatment as opposed to surgical management. And then there's the question about the cosmesis, which may play a role in conservative treatment. I like to make some of the listeners believe that non-operative treatment is the goal. I think scapula is the key, because it's very simple. After the AC separation, the clavicle and the scapula are separated. They're simply separate at 2 points. If we talk about grade 3, grade 4, 5, it's the coracoclavicular connection and the acromioclavicular connection. This means that the scapula plays a major role in the AC separation. Actually, it drops down. It's not necessarily the clavicle going up. And it does that because it loses its connection to the clavicle at 2 points. So the role of the scapula is very important in a conservative treatment, because when you separate at 2 points, it leads to significant disturbances in scapular and shoulder girdle biomechanics. So the goal of any treatment, conservative or operatively, is to restore shoulder function as close to normal as possible. And then you can ask yourself, is it really possible to restore anatomy and biomechanics by non-operative treatment as well as by surgical treatment? And how does the scapula and the shoulder girdle impact this? The primary goal of the treatment, I think we can agree on this, is to reestablish a connection between the scapula and the clavicle, thereby restoring biomechanics, because that makes the shoulder function well again. Non-operatively, you do this by addressing muscle function, by addressing the scapular stabilizers with an early rehab. I call that the functional approach. And surgically, you do this by reconstructing the 4 ligaments, which I call the anatomic approach. So the secondary goal is then to restore function independent of the radiologic results. So dislocation of the AC joint leads to a depression and an anterior tilting and internal rotation of the scapula. And this confuses the picture because it leads to additional symptoms that is not directly related to the AC joint. So when we do an MRI in these cases, do we actually look at associated injuries, or is it random findings? We'll sometimes see partial cuff tears, labral pathology. It's very often described in literature. But the thing is that if you correct the scapular position to normal position by a scapular assistance test or the retraction test as shown on the bottom of the slide, then the symptoms disappear. So we should be very much aware that these findings may be random, and we should avoid overtreatment. Again, the literature is not very strong, but this is a very interesting study by Gomina's group. 71% of patients with AC dislocations had scapular dyskinesis. And what they surprisingly found was that there was no difference in the constant score between the injured child and the healthy shoulder. But if they divided the group into those that had scapular dyskinesis and those that did not have, there was significant lower score with the scapular dyskinesis patients than those without scapular dyskinesis. And we found some similar figures. We found significantly lower WOSI score if the patients had scapular dyskinesis than went out with the same injury. So scapula plays a role. This is actually one of the largest papers about following patients after conservative treatment. It's from Peter Millet's group. It's a retrospective study, and they found that 71% successfully outcome of non-operative treatment. They concluded that the patients who presented with more than 30 days after injury were less likely to complete non-operative treatment successfully. I think this tells that you should intervene early, even with non-operative treatment. And back to Gomina's group, they just looked at some patients that had scapular dyskinesis and AC joint dislocation. And when they intervened and made a rehab program, they obtained good outcome scores. And they found that AC dislocation had been treated with a rehab protocol focusing on scapular stabilizing exercises. It diminishes the frequency of scapular dyskinesis significantly. They also found, as Millet's group, that patients that do not respond to rehab program will not improve with extended rehabilitation time. So that you have to take a new decision there. This is from our group at ISAKOS Opposite Extremity Committee. We tried to make a consensus suggestion that not looking only at the Rockwood's classification, but simply dividing these injuries into a stable type A or an unstable type B. The stable type A has a rapid improvement with no other treatment than physiotherapy. The scapular dyskinesis is not pronounced, and they often have a normal Basmania view. Whereas the unstable patient, it has no improvement. They have pain, they don't improve with physiotherapy, they have a scapular dyskinesis, and they have an override of the Basmania. So instead of saying type 1, 5, 3, 4, 5, 6, we could simply maybe divide the patients into a stable or a non-stable. And this is just an algorithm that was suggested. If you have an AC joint injury, you can have a clinical and radiological evaluation. You can divide the patients into the Rockwood types, and then you can choose non-surgical or surgical treatment. And then the key point is to evaluate the patients that were not operated after 3 to 6 weeks, just to see how are the patients doing. Do they still have pain? Do they still have scapular dyskinesis? Make an X-ray to see if you have overridden the distal clavicle. If they're still unstable and painful, you can opt for surgical treatment. If they have no overriding, then you continue with non-surgical treatment. And then again, if this fails, you can go back and call them 3B, opting for operative treatment. So we wanted to look into this. So we just finalized this study. It's a 100 consecutive, it's a prospective study of acute AC dislocations. And we want to look into the epidemiology, also the natural history, and try to analyze the prognostic factors just following a cohort. We just finished including the last one. We follow the patients for 6 weeks, 3 months, 6 months, and 1 year. So in 1 year, we will have the final results. So I have no results yet, but we have some tendencies. So one hypothesis was that we wanted to test the ISAKOS proposal of stable type A versus unstable type B. And we expect the results next year. So my preferred treatment strategy, if you have a grade 1, of course, you start with non-operative treatment. You can do physiotherapy. Some of them are very painful. You can do a cortisone injection. And grade 2, also non-operative treatment, same as grade 1. Some of these actually end out with a horizontal instability and need a docking technique for reconstruction of the AC ligaments. The grade 3 in Denmark is traditionally initial non-operative treatment for about 3 months. And before, our assumption was that about 15-20% then needed an operation. The study shows that it's less than 10%. It's very surprising. And then grade 4 and 5, the same initial non-operative treatment. And our guess was that approximately 40% with grade 5 need an operation. And in the study until now, we see it's only 10 to 15%. So this is what we do, and this is what the regime is. You start out for the first 4 weeks, pain relief. You guide the patient with passive and assisted range of motion. You focus on scapular alignment. And after 4 weeks, you aim at full range of motion at 6 to 8 weeks. Increase the strength training, increase still a focus on the scapular stabilization. And then 8 to 12 weeks, phase 3 is strength, skills, and scapula, and then they're back at the activities. So in conclusion, my experience, and I'm looking very much forward to our results, non-operative treatment may be successful in a majority of cases. I think this is already out in the literature. There's a correlation between a good outcome and a normal scapular function, so the focus should be on the scapula. If they had limited improvement for the first 6 weeks, it rarely leads to a good result. So these patients should be offered an operative treatment. I think we need newer, modern, well-designed randomized controlled trials comparing modern non-operative treatment as well as newer surgical methods. And I think it's important that we avoid over-treatment. Thank you very much.
Thank you. Thank you, Klaus. It was very nice. Very persuasive. So, our next speaker, Claudio, Dr. Rosso, is going to discuss about the operative treatment of AC joint dislocation.
Okay, thank you very much, Manos and Manos, for having me. It's a huge honor to be the first one and the battle with Klaus, who's very known for his AC joint studies. So I will try my best on telling you something about the operative treatment. However, I don't want the audience to be disappointed. I don't operate all of them. So I will give you some insight what I think. These are my disclosures. So you see these two X-rays. So on the left side, you can see Rockwood 2, on the right side, more or less Rockwood 3. So would you operate on the left one and the right one conservative? Would you operate both? We'll dig into this. I'm very proud to have led the ESA and ESCA. The ESA is the European Shoulder Associates of ESCA, on a consensus on how to treat AC joint dislocations. As Klaus said, and thank you very much for the huge introduction, so I don't need to do that anymore. And I figured that so there is a huge discrepancy, and we don't really know a lot about how to treat these injuries. That's why we were 40 surgeons to try to find a consensus, and if we agree on certain treatments, diagnostics, and I will show you a little bit into of it, but this is open access and you can download it of KSA at KSTA, so it's worth a read, I think. Klaus already told us a lot about what we currently know, just to pick some short points. As you know, the Rockwood classification is still valid, and we have the six different types, sorry. And type 1 and 2 is almost undisplaced. Mostly it's the scapula, it's not the clavicular. And then we have 4, which is more to the back. So it's within the trapezoidal fascia. 5 is more dislocated, and 6 is under the coracoid. And we ask our 40 surgeons, have you ever seen a type 6? And just 1 has seen a type 6 in a really bad injury, in a traffic accident. So type 6, I think it's possible, but I don't think we really have to discuss about this. These are the other 2 classifications out there, and I think they're not, they shouldn't be used anymore. So as Klaus said, and he was part of the ISOCOS consensus meeting, we have 3A and 3B. Basically, it's A and B. So just to tell you, B is the unstable AC joint with overriding and therapy-resistant scapular dysfunction, as we saw on the video of Klaus. We have a lot of radiographic measurements. A lot of people tried to, we have a static X-ray for a dynamic problem. And this is the problem we try to address with all the radiographic measurements we have. However, they're not really helping us a lot. And this is one of the views, the Alexander view, and very close to is also the Basmanian view, where you try to show the overriding of the clavicle over the acromion. Then we also don't know what is acute and what is a chronic injury, which guides us also how to treat those patients. And as Klaus said, we have over 160 types of operation. There are so many types out there. You can do either a figure of 8, you can do Weaver Dunn, you can do arthroscopic or open CC reconstruction with dog bone buttons or endobutton or whatever, or even a hook plate, which still some surgeons even here in Basel do. How do we treat them operatively? Sling, abduction brace, when do we start range of motion? You can fill a whole day just talking about AC joint, but I will try to emphasize some points. This is how we did it. We had 5 rounds, and in the end we found a consensus and we published it, which you're really happy to read. This is our group, our cohort of surgeons. We mostly treated between 10 and 50 AC joint dislocations per year. And this doesn't mean operative, but just conservative. So this is everything operative and conservative. So you see, there are very few who see more than 80 AC joints dislocations a year. What did we found? We consented that 3 weeks should be the threshold for acute and chronic. Why 3 weeks? It was suggested by Flint. We have a lot of people having said that it's 2 weeks only, the other 6 weeks. So we consented on 3 weeks, where everything might be still fresh, the AC joint still freshly disrupted, and the CC ligament still maybe prone to heal together if you put a suspensory device. We also agreed that the isocos grade 3B is sufficient, and that the Rockwood classification is comprehensive. And we also thought of maybe creating a new classification, but the Rockwood is established and it's okay. However, it was never really validated and not recommended, as I said, by Nestor and TOSI classification. When should you change from conservative to operative treatment? It's when you have persistent pain, and we did not consent on horizontal override. As Klaus said, the horizontal override is not really important. The important thing is the function of the patient, the function the patient wants and has. The Rockwood grade is not a parameter for changing from conservative to operative treatment, and not even discomfort. So this is a little overview on the left side. You can see the acute, how to treat acute stages, and on the right side, chronic. So as I said before, acute is less than 3 weeks. And the subacute stage is 4 to 5 weeks, and everything above 6 weeks is mostly considered to be a chronic injury. And then what did we consent on how to operate these patients? If there is an operation planned, so with the arthroscopically assisted suspensory device like a dog bone or an endo button. And then we should always address the AC joint capsule, which I will show later. This is a very important part, because at Dirna, he showed us that it's important to address not only the CC ligaments, but also the AC joint capsule. And no routine AC joint resection is recommended. And in the chronic operative treatments, we use a semi-tendon wrapped around the coracoid. Oh, this is recommended. And the acute setting, no graft is necessary. So to make it more vivid and not as boring as it was until now, I will show you some pictures. So this is a Rockwood 2 judo elite fighter. The picture I showed you before. I think most of us would not operate on him. Because first of all, he's a contact athlete because of judo. And second of all, the x-ray shows maybe a Rockwood 2. But is it a Rockwood 2? Is there A, B? Because this is something we were talking about. And I think Klaus mentioned it very nicely, that it's important to have a stable or unstable. So it doesn't depend if it's 2 or 3 or 4 or whatever. Is it stable or unstable? And even in the horizontal plane. And you know, in the last few years, we are talking more and more about horizontal instability. And here on the left side, you can see the picture of a horizontal override. Here you can see the clavicle, and here the acromion, and you have a horizontal overlap, which gives us a 2B. So what did I do? Even though he was a contact athlete, I operated on him. These are, I like the pictures, you know, just to show you what how you do a CC reconstruction. I think most of us know, but just for those who are maybe not as far and don't know what is CC reconstruction. So basically, with all the different devices you can use. This is one of the very good ones. So here you can see the scope in the back, and then you have a transbiceps portal, and then you have an anterior inferior lateral portal to manage all the sutures. And then you drill like 3.5 centimeters away from the AC joint. You drill a very small hole. This is very nice about this technique. And then in the end, you shuttle through this hole, you shuttle the dog bone button, it's called, through the coracoid, through the clavicle, and then there is the second dog bone button, which you put on top of the clavicle. So it is quite easy. You can do it all arthroscopic. Either you use a 70-degree scope from the back, which I really like to use it, or you use a 30-degree scope from anterolateral, the trans triceps, and it also gives you a very nice view. Sometimes the camera is a little bit in the way, but this is basically very easy. I use it without fluoroscopy because you should be afraid, of course, of the plexus, which is really very close and medial to the coracoid. But I don't know, I never had problems with this, to be honest. So what do we do after the operation? We consented on this kind of scheme. So immobilization, I immobilize my patients only 3 weeks with a simple sling, sometimes even with an abduction pillow, because it's more in a functional situation, and only passive motion, and then full range of motion at 3 or 6 weeks, and then you start weight bearing and return to full head activities, overhead activities at least after 3 months, and then full weight bearing at 3 to 4 months. Pain was defined as a criterion for return to activity, and this is the post-operative treatment, and also we consented that the conservative treatment would be the same. This is how it looked like, I think 1 year after, and you can still see, okay, maybe now it's a 3. No, but this is what sometimes we see, or most of the times, is that we lose reduction. And even I always over-reduce those patients, but we always lose reduction, and I still didn't find a way how to overcome that. So this is Rockwood 3, sports science student. As I said before, maybe he's what is he? Is he an A or a B? So here you have the bilateral Alexander views, and you can see there is no override. So this is a 3A, and this is, of course, non-operative. I did an MRI just I was just interested because it looked really like a 3A. And in the end, if you look at the CC ligaments, sorry, it's a little bit slow, the video. So here you can see his big supraspinatus, and then the trapezoid and the conoid is gone. So this is not, even although it looked in the X-ray, it looked like a 3. It was not really a 3 by definition, because with a 3 you should have a complete disruption of the CC ligaments. Here you can nicely see what happens with the AC joint capsule. It gets ripped off the clavicle, and this is also important to address this if you operate on this patient. But this is a 2A, and he was stable, and he's very, very fine. So what did I do? I see them on a weekly basis. 2 days after accident, you cannot address or really see horizontal instability. 1 week is not really conclusive, and at 2.5 weeks, we're already almost at 3 weeks, he didn't have a horizontal override. If it's still not conclusive, I inject local anesthetic, and then I can look at his AC joint if it's horizontal unstable. But this one was conservative. As I said, conservative treatment, almost the same as post-op treatment. This is a Rockwood 5 elite handball player. So you can really see a huge distance between the coracoid and the clavicle. And then also here you can see the big distance in the AC joint, which gives us a hint also on horizontal instability. And here on the left side, you can see the horizontal override compared to the other side, to the contralateral side. And you can really see that it goes up and back. This is the view, just to give you a view from the trans biceps portal. So you can see almost everything. And it's a nice view. If you don't have a 70-degree scope, I use 70 degrees, but this is own preference because you can do everything with 30-degree scope. This is how it should look in the end. So this is the coracoid of a left shoulder, posterior, anterior, and here you can see the dog bone button. And this is what I said before, the second dog bone is on top, and you tie the knots and really close the deltotrapezoidal fascia, which is really important because then the patient won't feel the knots so much anymore. Having said this already, over reduction intra-op, you can see the clavicle is much closer to the coracoid as it should be, because I know that I will lose reduction. This is after 1 year. So again, I lost in the near, I lost a little bit of reduction in the AP. It still looks fine. So this is the patient. And another thing, I just want to have a short, do I still have time to go into this?
Okay, yes, but we would like to discuss also after this. But please.
Sure, I'll have a quick run on this one. So I had a chronic Rockwood 3. Just to go quickly through this, and here you can see on the left side, you can see the horizontal override and the clavicle that is higher. And here we use, as we consented, the tendon grafts. So you go through the clavicle with the tendon and through the coracoid, and then in front of the coracoid again. So this is a very nice technique published by my friend and colleague Martin Schläger-Frank. He's really a good guy, and this is a very nice technique, and it has been published, and you can look this up. And I won't go into it by looking at the videos. However, this patient had a fall again, 8 months post-op, and you can see the AC joint distance and the tunnel widening. However, he didn't lose a lot of horizontal space, but he lost a lot of on horizontal instability, but he's fine. So initially on his chronic AC joint, he wanted an operation, but now that he's almost the same again, he doesn't want it, and he's fine. So, and he's also fine with the cosmesis, as Klaus said. So this is my algorithm to conclude. I do X-rays through AP and the near and the modified Alexander views. For me, it's important to check for the Rockwood classification. However, I divide them like Klaus published on A and B. And if I operate, I always address the AC joint capsule, because this is an important factor, as has been shown by Felix. And the MRI is really rarely needed. I thank you for your attention, and let's go into the discussion.
Thank you, Claudio. Very nice presentation.
Thank you.
Thank you, both of you.
Thank you, both of you,
Thank you.
because it's difficult. It's not going to be a fight, rather a consensus. I think that what we have understand is that what we see in X-rays is not the whole story. And what we see in an AP view, the vertical instability, maybe is not the most important factor for the situation. The other part, the horizontal, is what is important, probably. And this is a consensus in ISAPOS, and this is what we found also with in ESA. And I don't know if you agree. What we have to find is to find the techniques that are of low morbidity, and they can restore both both components of the instability. And this makes Frank's Martenslager technique so interesting. It's something that I use also when I came in contact with this idea. It's a little different, but practically it's the same thing. And I think that you would agree that this kind of techniques and a very selective approach to the patient, to the patients that are going to be operated, is the most important factor in this problem. What do you say, Klaus? What do you think?
About the technique?
About the technique and about the selection of patients. Good?
I agree that, and I think Claudia mentioned this very clearly, that it's very difficult with the radiographic evaluation because we don't have the perfect test. And actually the override of Basmania, Claudia mentioned that this is not necessarily the same as unstable, and I agree. And this is what we hope we can see from this study, because there may not be this correlation. It was only a hypothesis. But I think, and Claudia also mentioned this, I think the most important factor here is the horizontal instability. I have seen type 2 patients with horizontal instability where you have to actually grab the joint and make an AP test just to be sure. And even if the X-ray looks good and the Alexander view looks good, they can be completely unstable. These patients are extremely in very much pain and don't do any progression. And you say, oh, it's only a type 2. But the problem is they are unstable, they are painful. So we have to find, I think it's a mix of the radiographic and the clinical evaluation. And then again, of course, the patient's perception, how does it go? If they progress, it's no problem. And I think that has something to do with horizontal instability. If you continue to have problems, I think the key is the horizontal instability.
Klaus, may I ask you something? For horizontal instability, how do you diagnose horizontal instability? Only clinically, or there is some radiological test that can quantify the horizontal instability?
We use the Basmania view or the Alexander Aufnahme. And then I combine this with my clinical testing, which will be an AP test of the AP instability, and also to make a cross-body adduction, and they are very painful if you have the horizontal instability. You can actually see the lateral clavicle going back. But I think we need better dynamic evaluation. Maybe it can be done by sonography and ultrasound. I think we need some better methods, but still you have to combine clinical findings and radiographic findings.
Okay.
I would agree. Sorry, Manos. I would agree with Claudio that the follow-up after the initial acute injury is very important. All the patients during the first week are painful, but those that they are stable are becoming unpainful and regain shoulder function quickly. So at about 3 to 4 weeks, you have an idea of who is not going to go well and who is going to go well. And this is, for me at least, this is the most important criterion. And also the clinical examination, the motion of the clavicle back and forth when you examine these painful patients. These patients that are still in pain after 3 to 4 weeks. So, Manos.
Okay, Claudio, I would like to ask you, based on what you choose a patient to go operatively against non-operatively? And also, this is the same question from Alexander Landerman. Do you have a test or a sign that you push you to go to surgical management?
I don't have as Klaus said, I have the combination between the Alexander view and the horizontal override in adduction, and also the horizontal or the instability if you grab the if you grab the clavicle. But there is nothing published really on that, and I'm mostly, if the patient is in pain but getting better, I'm choosing conservative treatment, because I know that we have loss of reduction, we have problems in contact athletes that the clavicle might break. So this I always keep it in mind, And if it's unclear and if it's not really clear, I go for conservative treatment. So in the end, this is not really a mini battle with Klaus, but it's more like maybe I'm a little bit more going into operation, but really not that much. I do a lot of conservative treatment, and there is no single sign. It's more a combination of everything to go into an operation or not.
The concept of mini battle is not to battle actually, but to see the same thing from a different angle. So this is the concept. So don't worry, we don't
Okay.
hold down your gloves. Okay. Do you believe that CT, and this is for both of you, do you believe that the 3D CT reconstruction or the MRI or some other radiological examination, maybe an arthrogram, let's say, do you believe that can offer some more to the evaluation?
Klaus?
Yeah, you have the question. Now, I don't have any good experience with just using still imaging like the 3D CT. So I think we need a dynamic radiologic examination to be quite sure. And I think the Alexander now is the most precise now, even if it's a static picture. So I think it's the same answer. You have to look at the patient at the same time. I always had troubles with MRIs because sometimes you see something and then it's not necessarily the problem. Like arthritis of the AC joint is very common, but it may not be the problem. So you should be very critical by using imaging. I don't think we have the best method yet for like proving what we see with our eyes and hands.
I absolutely agree.
Okay.
I think that the problem that we have to do for decision making about operative treatment is more difficult in acute cases. In chronic cases, things are simple. Patients usually, those that are not having problem, do not come to us. They come to us when they have another problem, and then we see that there is a dislocated AC joint also. If they're asymptomatic, then no one is going to operate on them. If they are symptomatic, it's a chronic symptomatic situation, and all are going to be operated. So the problem is what we are doing with acute cases. And in this case, I think it's better to wait for a while, because in about a month, you have a better idea of what is going to happen with this patient. And still in a month, you are still in the acute phase where you can use only sutures, a simple technique than using grafts for restoring the stability of the joint.
That's what I
think the idea is clinical. The solution is clinical in the acute cases, to follow them for a while, follow them closely, and make decisions early.
May I say something?
Of course.
That's what I wanted to ask Klaus. Like, if after, let's say, 3 weeks, the patient is in pain and not stable, do you go on with conservative treatment, or do you plan surgery? And do you already augment it then, or do you just do a CC reconstruction?
So at 3 weeks is it's not 2 and it's not 6. So that's what you found in your consensus. And I haven't seen any cases actually. Only for some reason, type 2 I've seen still being painful at that stage. I would still give them a little more rehab. I know that this is a time problem, because then you cannot avoid to augment the CC ligaments. So, and you see, with my practice, I would see very few with a need for an acute reconstructions. So.
And after how many days or weeks do you consider to add an allograft or an autograft, your repair?
So normally we have this plan that it's at least 3 months of rehab, but like the literature shows, my cutoff point is about 6 weeks. So 6 weeks without progression, you have to augment it at that time. And also you mentioned about the chronic cases. It's a little more easy for some reason, but if you have a chronic case that never saw a physiotherapist, I would still, you have no time to lose. I mean, you can still give them a chance and try that. But if that fails, you can still do the augmentation. So that the chronic cases, you don't have any time issue.
Can I ask you something, Cole? What I saw in my practice that this loss of reduction that Claudio referred to is very common, and especially when you address only the vertical component of the stability. And when I was doing this type of treatment, I had a lot of patients that they are losing at least some of the reduction. Then when we start adding the horizontal component, then this patient, we are now following the patients and we are taking X-rays to see what's happening. But the impression is that the patients that are losing reduction are less, even in the vertical plane. And maybe the addition of the horizontal component of the stability, the stabilization of the horizontal component of the stability lowers also the loss of reduction. I think that by increasing a little the time of the operation and doing something for the AC ligaments is having a big difference both in the clinical result and in the radiological result. What is your experience?
What is?
Yeah, I think that that might be a problem. So another question: do you just suture the AC joint capsule, or do you really like reinforce it using like Effie bond or whatever, or fiber wire?
We take the sutures from the horizontal part, from the vertical part, and then pass them through the AC joint and under the acromion, and then we make a next stabilization, and next type of stabilization, something very similar to what Frank Maslager is doing. And we do it arthroscopic, checking the AC joint from the underside, from the subacromial space. And this is how we do it. And then we suture also the ligaments, the superficial ligaments of the AC joint.
Yeah, I don't routinely do that, but this might be an important point, as you said, that addressing also the horizontal part, not just by suturing the AC joint capsule, but really by reinforcing it using some kind of sutures. Klaus, what do you do?
Yeah, I do the same. I do them on a later stage, and I use a fiber tape to reinforce the AC joint. But also, I saw maybe 2 cases, female with very fragile bone, not necessarily good for a very solid tape. So sometimes I simply don't do it. I just use the tendon.
Okay, yeah. In the chronic cases, I always address the AC joint with a figure of 8 or with the X. But for the acute cases, I don't routinely do that. Yeah.
The interest seems to raising because there are many questions, and one of them is for you, Klaus, for your study. Which was your exclusion criteria? Did you have exclusion criteria in your study, in your sample?
Yeah, I think those patients that are not able to cooperate, like mental illness, severe illness of some kind, and if they had an injury to that joint before, they were excluded.
Okay. And also the question is, how do you address the capsule? I think they say about the deltotrapezoid fascia. Really, this is a myth or this is a reality? What do you believe?
for the grade 5, you think?
Το trapezoid fascia.
Yeah, if I close it, I close it if you have, if it's a grade 5, I definitely do a closure of that fascia because it's very important. I think it's called the 5th ligament.
Claudio?
Yeah, I agree. As I said before, I think it's a key factor, and maybe there might be a horizontal or a dynamic component to that fascia, stabilizing, also having a stabilizing factor. But of course, the fascia, if you know how it looks like, it's very thick, and I always address it and I suture it with Vicryl.
Okay. So, okay. There is a question in revision cases. Do you use routinely an autograph to reinforce the construct? I think everyone
Yes.
agree to this. Okay.
Yes.
Yes, I do.
Okay. So, Claudio, do you prefer a dog bone under the coracoid, or do you loop your tapes, your sutures?
You mean in the chronic cases if I augment?
No. From down and under the coracoid, you put a dog bone, or you loop your sutures.
No, I always put a dog bone underneath, and if you have the coracoid here, I put it really on the knee, so really very close to the scapular body, because if you put it too far on the front of the coracoid where the conjoint tendon is, it might fracture. And here is the strongest bone also that has been shown. And I try to put my dog bone really very, very close to the body. And I always use a dog bone going through the coracoid. And I don't think wrapping around it, if you wrap something around it, it might slip. And I don't have experience with that, and I wouldn't trust.
Okay, I prefer to loop the sutures under the coracoid, either tapes or a looped suture. And when we tie the sutures, we see that the sutures go to the shoulder of the coracoid by themselves, because this is where they are driven by the forces, the pressure that you apply when you stabilize the clamp. And we've had not problems with loss of reduction combining with horizontal stabilization. And I had some fractures of the coracoid, and I'm very afraid of doing holes in the coracoid. And when we used the double dog bone technique, where we used two holes in the coracoid, I had cases that they broke the coracoid, and the two holes were connected by broken the coracoid. So losing the reduction and the coracoid and two dog bones, trying to remove them, it was a nightmare.
Do you experience post-operatively osteolysis of the distal clavicle, and do you treat it if it's painful? There's a question from the audience.
For me?
Yes.
Yeah. Yes, I've seen osteolysis, especially in the chronic cases. I think if you remember one of the the chronic one, he had osteolysis a little bit, but he had a fall again. And now, even with the osteolysis, he's fine. However, in the other cases, I have not seen that much, to be honest. Yeah, I don't know why, but this is, for me, it's not an issue, except for the chronic. But in the acute, no.
I've seen some cases having we were done maybe 10 years before that not only developed osteolysis, but also like a resorption of the distal clavicle. We have maybe x-rays half a year after surgery, and then 10 years after, some part of the clavicle is missing. So I think it can be a definite resorption taking place as well.
Klaus, also a question for the audience. What do you believe about splints? Do you have any special splint that you use?
Is it for postoperatively or for the conservative?
No,
just
conservatively.
No, it's simply that it's a simple sling. It's just for relieving pain. And there was a regime once where they said they had the sling for 6 weeks, but it's not necessary. They had to move the arm relatively fast when the pain is gone. So it's only for maybe 1 or 2 weeks, depending on the pain. So no special splints.
Okay.
We used splints when I was young, and we used slings trying to press the clavicle or raise the arm. And it was a nightmare because we were torturing the patient, and we had some sores, pressure sores in the clavicle also. And we were looking for plastic surgeons to repair the skin and on top of the shoulder. So we abandoned them completely. So we treat functionally the patient, allow them to do as much as they can if they decide for conservative treatment. We try to regain function as soon as possible, as pain allows. Pain is the only reason to avoid doing something.
I know you're both experienced with athletes, and I wonder, athletes are more keen to go operatively or no, because they need a more predictable outcome sometimes. But which is your experience? This is better. It's always better with the surgical management.
Well, I think that for athletes, overhead athletes especially, it depends on what kind of athlete they are and what their demands are, because I have had elite handball, national team handball players playing like 2 days after a grade 5. So they don't bother about pain, they just want to play. On the other hand, we had a very good goalkeeper, and it was his right arm. So he should be able to throw, and he should be able to actually not fear landing on that side. And it was a grade 5. So in that case, I think you can say that there's a bigger need for a quick stabilization procedure. It takes a little more with the rehab, but then maybe you have a more long-lasting result.
Claudio?
Yeah, so I agree. It depends on what kind of sports. So this is something that Knut and I were looking at to have predictors of failure. And we wanted to include this into the consensus, but it was in the end too much. But still, we still have the data. So is the patient a contact athlete like hockey? Is he overhead, like Klaus said, or is he a heavy worker as well? So these are the patients that might be prone to failure if they have to lift too heavy things, So contact athletes like hockey players, they all have like 5s on their shoulder, and they're fine with it. And with this high contact sport, I would not go into surgery, and I know that they're very fine with it, because then I'm really afraid that if they bump against the other player, or against the wall, as they usually do, they might fracture their clavicle and or their coracoid. And they don't need too much overhead. Hockey players are down here. So with hockey players, usually I don't go into surgery. If it's overhead athletes, as Klaus said, it really depends. But it really depends on, is it the dominant arm? Is it the adominant arm? Adominant, less surgery, dominant, more surgery. But yeah, you have to look at the patient. But the high contact athletes, I don't do them.
There is a question if there is any experience to use a conjoint, the half of the conjoint tendon as an autograft from Peter Domos. I don't know. Does anyone has experience with this?
No,
I don't. No.
Okay, neither me. And also in a Rockwood type 4, what do you tell to your patient in terms of success rate for an acute repair?
again, it depends on the patient. So is it a 20-year-old overhead athlete, or is it, let's say, 70-year-old man that still does a lot of sports? We see a lot of 70-year-olds that are really fit. It depends, but usually type 4s, I go into operation because they're stuck in the back and I want to reduce them. And the success rate is good. It's very good. And also literature tells us.
Okay. And one last question is, if we decide to go for surgical treatment in a chronic setting, do you think it will be enough with SSA ligament reconstruction?
No.
Without augmentation?
No.
I think that horizontal stability is always exists in these cases. Okay.
Yeah, you need biology. You need to bring biology into that construct because, you know, the ligaments are retracted. And, you know, if you have just the fiber tape or whatever tape you have between the coracoid and the clavicle and nothing biological, it will fail because you will have the helicopter effect on one side and you will have fractures. So in chronic cases, which more or less 6 weeks, go for augmentation.
Okay.
I agree.
Okay. I would like to thank the audience for the question, and I would like to thank both of you. And now let's have one more poll. Please vote your preferred treatment option for an acute type 3 AC joint dislocation. Let's give some seconds because there is some connection delay sometimes. And if we can have the results of both polls in our screens, it will be desirable. Okay, this is the results. The vast majority prefer non-operative treatment, 68% versus 32% operative treatment. I think that both of you give your opinion to this, and I think it's the same. And which is your preferred option for an acute type 3 AC joint dislocation? The same answer, 67% non-operative and 30% operative. I don't know, Dr. Antonogiannakis, do you agree with this?
Yes, practically. about 70% of the patients are going to be well non-operatively, and this is the experience that if you see chronic AC dislocators, about 70% of them are going to be okay, 30% are going to have problems. The problem with the chronic dislocators is that many of them have changing the way of life, their activities, in order to stop having symptoms. And this is something that it's difficult to discover when you are doing a natural history type of study. That many patients find, practically we want the patient to compensate for the injury. And many patients compensating by avoiding some type of activity. And these patients are also included in the good result of conservative treatment. It's not a real good result of conservative treatment, because patients change activities in order to avoid having symptoms.
Okay, I would like to thank both of you for your participation in this pilot episode, in this first episode of this series. And I would like to ask for the audience to help us in this pilot episode with in order to improve ourselves. And this can be done by completing a questionnaire after the end of the meeting. And I would like to thank you once again for being here.
Thank you, Klaus. Thank you, Claudio.
Thank you.
Thank you for having me. Thank you very much. Enjoy the evening to all of you.
Bye.
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 Bye to everyone.
Hello, gentlemen.
Hi, Peter.
Hello.